Thank you for inviting me to present at this wonderful conference. I'm very glad to speak to you this evening. I'm going to talk about updating the activities of the National Dental PBRN. Well, it turns out that much of practice-based research network is relatively recent. Medical PBRNs began in the 1970s or so. Dental PBRNs did not begin until the early 2000s. And this is unfortunate because we finally realized in the 2000s that there's an immense amount of practical clinical wisdom out in the community, dentist in everyday clinical practice that until then was essentially ignored. This is a big problem because if we want more evidence-based practice, we need more practice-based evidence. So what if we actually conducted the research in the clinical settings where just about everyone gets their care? So that's what we're looking to accomplish. So we've been doing this since roughly 2004, 2005 in the National Dental Paper. We did have a Alabama Dental Paper for a couple years before that. So why do practitioners do this? Well, they do it for a wide range of reasons. And this slide lists reasons that they themselves tell us why they do it. So this is not something that we came up with. This is what they tell us. They tell us that it increases the stature of their practice, that it conveys to patients that I quote, stay current. This is a result of some patient focus groups that we conducted. And a recurring theme was that patients liked the idea that their practice, their dentist, was participating in a PBRN because it must mean that their dentist is trying to stay current, and they like that. That was important to them. Dentists also tell us that it's the participation in PBRN provides new rewarding collegial interactions. Dental practice can be isolating or lonely at times, and it's nice to engage colleagues, to compare notes, to get their viewpoints on the latest clinical techniques. And so practitioners enjoy that. They also tell us that they appreciate being compensated for the time that they get compensated for the time spent doing research. So we do not pay them for doing the clinical care. They get paid for that anyway. However, we do compensate them for clinical studies for the time that it takes to do the research. And by that, I mean getting patient-informed consent, recording information on the data forms, interacting with our research assistants doing the study, and then closing out the study in their practice after all the data collection has ended. They also tell us that they like participating as much or as little as they like. So some practitioners enroll in the newsletter and that's all they do. Others get a newsletter plus they participate in questionnaire studies. Others do that plus participate in clinical studies. Some participate in only one or two clinical studies. Some participate in more than one at any particular time. They're doing multiple studies at a time. So there's a wide variety in the participation level of practitioners on the network. And they consider that a benefit of network participation, that they are the ones that get to decide how much or how little they participate. We also reach out to practitioners to ask them to provide us how interesting, meaningful, productive their participation is. And we sometimes get them to provide testimonials. And here's an example from Dr. Stone. He says that my participation with PBRN over the years has been one of the highlights of my career. The opportunity to take part in well-designed clinical studies has improved the quality of care I was able to provide and elevated my office in many ways, from enhancing the way both patients and team members felt about the office to improving our procedures on a daily basis and being a valued member of the PBRN. So this slide says, I was just rubbing sticks together for fun. I didn't realize I was doing basic research. This underscores the power of an individual practice's contribution. So this allows us to have a large national study, but its impact on any individual practice can be pretty limited. Let me give an example. We did a study called the Cracked Tooth Registry. It enrolled approximately 3,000 teeth across the nation. This is the largest study that's ever been done that follows up cracked teeth. So 3,000 teeth is a large number, but we only asked individual practitioners to enroll about 20 teeth because we enrolled 150 practitioners. So with 150 practitioners and 20 teeth per practitioner, that got us 3,000 teeth across the nation. So 20 teeth is a very manageable amount for an individual practice. It took them a matter of a few weeks to do the study. So we were able to accomplish a lot without unduly impacting any individual practitioner. We also know that practitioners generally like to see one of their own up at the front of the room presenting results. Now, I could present results myself as an academic dentist. However, it's more impactful. It's more credible. It's viewed as more feasible if one of their fellow practitioners who participate in the study is the one actually presenting the findings. They find practitioners in the audience find that more validating. And so that can actually help encourage practitioners in the audience to change their everyday clinical practice. We also make a point of making study participation as unburdensome as we can possibly think to do. So we work with the practitioners and their staff very closely. We do as much for them as we are able to do, therefore making it less burdensome for them. And they appreciate that. They consider this concierge research. That is, they've got their own person, concierge research assistant, working with them to help make the study as good as it can be for their particular practice. They get individual attention. We are a national network. It's administered nationally at University of Alabama at Birmingham. We also have 6 regions nationally, as shown here on the map. We are indeed a national network, and for all of our clinical studies, we ask patients to record the zip code of residence. So this is a postal code. And this allows us to place on a map the patient's area of residence. And you can see from this map that we have indeed now engaged patients in all 50 U.S. states, as well as Puerto Rico and the District of Columbia. So we are truly a national network. Many years ago, dental PBRNs, people would come to us and say that this is not something that will work. They actually encouraged us not to proceed because they were so convinced that it wouldn't work. They felt that dentists would not be good at doing studies, that they wouldn't do them properly, that sort of thing. So we've proven them wrong time and time again. The studies can be productive. Dentists and practices can do a very good job of conducting studies. And we've shown that dental PBRNs can be both productive and impactful. And we measure that several ways. This slide shows some kind of academic measures of productivity and impact. One measure is how many peer-reviewed scientific publications we have had. Currently, we're at 241. We also keep track of something called a relative citation ratio, and I will explain that more on the next slide. But our relative citation ratio is 1.4. A score of 1.0 would put us at about the 50th percentile. So we're above that, and we're very happy about that. And again, I'll detail that more on the next slide. We have enrolled more than 78,000 patients from across the nation. We've engaged a very broad range of study designs. We've done cross-sectional studies. We've done prospective cohort studies, retrospective cohort studies, case control studies, case series studies, randomized controlled clinical trials. So we've done just about every study design that there is, and we've shown that dentists in everyday clinical practice can do these studies successfully. We've also engaged a very broad range of clinical topics. They have covered a very broad range of topics that are of interest to general dentists as well as dental specialists. They have ranged anywhere from smoking cessation to temporomandibular joint dysfunction, orthodontic care, endodontic care, restorative dentistry care, etc. We've also published these 241 publications in 72 different journal titles. And so we use that as a measure of the breadth of the range of topics that we've investigated. We've done a large number of studies, as 57 in number. So I mentioned in the previous slide this relative citation ratio. This is something developed by the U.S. National Institutes of Health. And it was done to address the limitations of other measures of scientific impact. So it is common for a measure of scientific impact to be the impact factor of a particular journal. However, there can be good articles published in low-impact journals and poor articles published in high-impact journals. So the journal impact factor is a very crude measure of impact for a particular article. So they developed this measure, relative citation ratio, so it could be article specific. So what is an impact of a specific article? It's also adjusted for the size of the research field. So for example, if we were doing cancer research or say immunology research, we would expect more citations simply because those fields are so much larger than dental research. So it's adjusted for the size of the research field as well. And I mentioned before that a relative citation ratio of 1.0 equates to approximately a 50th percentile. And this is a very easy thing to analyze. Every article in PubMed has a PubMed ID. You simply paste it into the website here, and it instantly provides a nice report about the relative citation ratio. So we're very happy that we demonstrated impact using this relative citation ratio in our network. So the big picture is that we ultimately would like to be able to transform the profession of dentistry. And this is enabled because PBRN research is really operating at the overlap between research and quality improvement. It is research, but it's research that we want to be immediately applicable to everyday clinical practice so that dentists in these settings can very quickly use this information to improve their practice, to improve their everyday clinical care. And that's where the quality improvement, continuous quality improvement notion comes into play. So our long-range vision is that all dentists would incorporate research and quality improvement activities into their everyday clinical practice. They would do this just because that's what we do as a profession, so that every dentist would be doing research or quality improvement of some type. So, for example, they may be at a social activity or a party one day, and they happen to be talking to other people in the room who are not dentists, and they ask what they do for a living. They say they're a dentist, and someone asks, "Oh, do you happen to do any research in your practice?" And we'd love it if the dentist would respond, "Well, yes, of course, I'm a dentist. That's just what we do as part of our profession." We're not there yet. We are there already for the dentist in the network, but the dentists down the network only comprise something less than 5% of dentists in the entire United States. So we have a long way to go. We'd love for that figure to be the majority of dentists, but we're not there yet. But at least we are there for the dentists who are participating in the network. So we exert a lot of effort to generate clinical evidence. So we want practitioners in everyday clinical practice to use that evidence to improve their clinical care. So because of that, we have conducted studies that measure what percent of dentists in everyday clinical practice are actually doing clinical practice consistent with what the evidence says they should be doing. So the evidence says they should be doing a particular treatment, and we're wanting to know what percent of dentists out in everyday clinical practice are actually doing that treatment. So we measure the concordance or agreement between what the evidence says should be happening and what they are actually doing. And for this study, we found that to be about 62%. So we would consider that a medium level concordance. We'd like it to be higher, but at least it is the majority. We found that dentists who were in large group practices were more likely to be concordant with the evidence. We also found that if the dentists were engaged heavily in the PBRN, that made them more likely to change their practice to incorporate the evidence that they themselves have generated. And this practice change was the strongest among the practitioners who were most engaged in the network. These are the ones who attended the annual meetings, who participated in clinical studies, who participated in questionnaire studies, who read the newsletter, who talked about their network activity. And so they were more likely to change their practice as a result of that higher level of engagement. We also found that if those highly engaged practitioners were in a clinic with other dentists, and these dentists were themselves not engaged in the network, those dentists themselves were more likely to engage in practitioner change. So we refer to that as a spillover effect. So the dentists who were engaged in this practice were more likely to change their practice based on their network participation. And because they mentioned this, discussed it with the other dentists in their network, those dentists themselves were more likely to engage in practice change, even though they were not participating in the network. We have also been productive at engaging national clinical organizations in our network, and I'll call on two examples. One was the American Association of Orthodontists, the other is the American Association of Endodontists. The American Association of Orthodontists we collaborated with on a national study of adult anterior open bite. This is a treatment that happens in adults where the anterior sextant of the mouth is remained open, so it's not an occlusion. Treatment is typically very effective, but it may relapse. So these teeth are occluding by the end of treatment, but it tends to relapse over the subsequent years to even back to the point where they were before treatment. So we're interested in what treatments were successful in maintaining the situation after the end of the treatment so that it did not relapse. So we engaged the AAO members to identify research topics, and one of those topics that they were very interested in investigating was adult anterior open bite. So that's the one that we started out with because of that. The AAO also helped us recruit orthodontists to participate in the study. They even formed a PBRN committee to help us design this study. All of this activity led to 7 publications from this anterior open bite study. And these publications had a very high relative citation ratio, 2.6, so that's very high. So we felt like this was a very successful collaboration. We engaged the members in a study that they wanted to participate in. The study was well done because of our engagement with the AAO. It led to a significant number of publications, and these publications were impactful. We also engaged the American Association of Endodontists. They also polled their members to identify research topics. They also formed a PBRN committee to help us design studies. They included news items in their organization's newsletter to update their membership about the collaboration, as well as to help recruit members into the studies that we conducted. We conducted several studies with them. They also developed a national case difficulty assessment form. They had one developed already, but as a result of their helping us design a PBRN study, they revised it because they realized that they needed to adapt it better to the everyday clinical context. And the hope was that this difficulty assessment form would help identify before treatment cases that would ultimately be determined, labeled as difficult cases, either during intraoperative or postoperative assessment. And that ended up being the case, as I'll talk about on the next slide. But we end up doing 7 clinical and questionnaire studies in collaboration with the endodontic group. This has led so far to 25 publications. These publications have also had a high relative citation ratio, 1.7. On the first 18 publications, the other ones have not been out long enough to have a relative citation ratio yet. So what did we investigate? Well, we found we measured the prevalence and the nature of persistent pain, including non-odontogenic sources. For example, one study we evaluated pain after root canal treatment had been completed for more than 6 months. And it turns out that I believe it was about 4 or 5% of patients who had completed their root canal treatment more than 6 months before still had pain. So why was that? Well, it turns out that a significant percentage of them still had pain because their pain was not of endodontic origin, even though they had received a root canal. Instead, their pain was from temporomandibular joint dysfunction or related non-odontogenic sources. We've also identified predictors of postoperative pain, helping the clinicians tailor management. We help them better anticipate treatment outcomes using this case difficulty assessment form. So we had dentists, general dentists, and endodontists assess the difficulty of the endodontic case before they began treatment. And that was predictive of having difficulties during and after the treatment. We identified procedural differences between general dentists and endodontists. We also identified that there are a significant percentage of dentists, general dentists, who are not using a rubber dam for all endodontic treatment. That is considered the standard of care. In fact, the American Association of Endodontists has a position paper that says all root canal, non-surgical root canal treatment should be done using a rubber dam for various reasons that I won't get into. So we had always assumed that this was the actual standard of care, but when we actually measured it, we asked dentists on questionnaires, and then later we measured it on actual clinical care, that not everyone is following this standard of care. So we presumed that it was a standard of care, but it was not actual standard of care. We've also identified treatment referral pathways and the types of patients that general dentists and endodontists treat. So that's a broad overview of our activities since I've talked with your network in the past. We would welcome you to join the network. Now, as a non-US dentist, That's just going to get you a newsletter. You would not be able to participate in our clinical studies, but nonetheless, we would welcome you to join the network so you can keep up on the latest news. Thank you very much.